Okay, we just started recording, so yeah, Tansu, please go ahead.
Awesome. All right. So today we will have six aliquots, and in the sixth aliquot, I will reveal the final diagnosis, and I will have some teaching points at the end. So here we go. We have a 22-year-old female patient today with pain, redness, and swelling in both hands, proximal interphalangeal joints of the fifth digits bilaterally. And if you want, I can give you a little bit of the HPI. So 10 days after this patient's joint symptoms started, she had a 14-hour bus ride where she noticed she felt uncomfortable in her usually normal fitting pants. And 3 days later, she had a 4-hour plane ride where she developed facial edema. And over this time, her joint pain generalized to the other digits and wrists that lasted for half an hour in the morning, and then it decreased but didn't go away completely. And during this time, she also noticed that her urine became darker and she had watery diarrhea, but with no blood or mucus, no nausea or vomiting, and she had some cough with sputum production. And the mic is to you.
Thank you, Tansu. Such an interesting aliquot. Since we haven't discussed who's going to do the first, maybe I'll start for this aliquot and then Alec and Austin can join. So yeah, I think it was an interesting chief complaint in a young female with what seems to be like arthritis kind of picture in the proximal interphalangeal joints, but only involves the fifth digits. At first, my thought jumps to like a arthritis picture, thinking involving the small hands. Although like her age may be a little bit too young for the common things we think of like rheumatoid arthritis, but I think that is still possible. So my thoughts was around like polyarthritis, and then the differential would also include like it seems to be like inflammatory, and I have like this imaging like in front of my thoughts, like how different types of inflammatory arthritis involves certain have a propensity to certain joints. But I have to kind of refresh a little bit, like which is the fifth digit. But proximal seems to be like the typical inflammatory arthritis. And then I have to kind of digest the HPI a little bit more. Maybe at this time I'll pass on my mic to Alec and Austin to maybe share more thoughts about with the addition of HPI.
Thanks so much, Mengyu, for really starting us off well. I think I'm still struggling to figure out, where to anchor myself and how to define the problem. So I think I'll just go through each things individually. And, I think Mengyu did a great job, and that the initial history is sort of evocative of an inflammatory, likely arthritis with the swelling that was noticed. But I'm sort of looking at this more sort of ending acute to subacute time course here of seemingly things starting distally, either in the lower extremities or the upper extremities, and sort of progressing their way centrally. And fairly struck about how a young woman, seemingly otherwise healthy, but the background will be really important here, that she's what I'm sort of translating to normal fitting pants now being tied to edema and working its way up to the facial swelling, which facial swelling in and of itself is not particularly common. And, usually I think about facial swelling either related to a localized trauma or an infection, like orbital cellulitis being a good example, or being a part of systemic syndrome like anasarca. And also not forgetting the vascular etiology is most commonly thinking about SVC syndrome as well, and what the risk factors are related to that. But I think this is just really sort of beginning to paint a picture of a systemic syndrome characterized by arthritis, potentially renal involvement with a different color urine, and then also whether the GAI attractor is involved is a little unclear because diarrhea frequently can be nonspecific, and whether there's pulmonary involvement as well, either secondary to renal involvement or a completely involved as a separate system entirely as well. So getting a flavor of a multi-systemic involvement, including the lungs, the kidney, the joints, potentially other organs as well. And I think here, I think really getting a good physical exam to know what exactly we're dealing with as far as the arthritis, actually confirming that this is edema, and then layering in the background of the past medical history, other pertinent things as well. And then just a comment on, seems like this person has been immobile for some time, 14 hours on a bus, and then, another 4-hour plane ride, and whether that can increase the risk of thrombosis. Although most people, young people, particularly that are healthy otherwise, that travel, don't usually get clots. So whether or not there's a predisposition related to that. But I think here, it's hard to really know where to anchor myself, and just know that I'm getting a sense of inflammation and multisystemic involvement, and hope to get more clarity with the history and examination. But Austin, I would love to hear what thoughts you have as well.
No, nothing to add. I think you both really touched everything. So excited to hear more.
All right, perfect. Thank you so much. Great thoughts. So her past medical history is not significant for any disease. She doesn't have any past medical history. She recently used herbal supplements for 4 months, and she dropped from 65 kilograms. That's for my friends who use the metric system, which is 143 pounds, to 56 kilograms, which is 114 pounds over the past 9 months. And her family history is significant for in her mother, who is 50 years old. She has hypertension for 3 years, and her father, who is 55 years old, had been diagnosed with type 2 diabetes 10 years ago. He also has hypertension, coronary artery disease, and she has 2 siblings who are older with no past medical history. She's a college student living in Turkey in a dormitory with 3 other female students. And she doesn't use any alcohol or drugs, but she's a smoker. She smokes 1 pack a day for the past 3 years, so 3-pack years, and she doesn't exercise. And she states that her diet has been unhealthy because of eating the like dormitory food. And she doesn't have any allergies. So going on to her vitals, her temperature is 37.2. Her heart rate is 122. Blood pressure is 99/56. Respiratory rate 16. She is saturating at 98% on room air. And in her physical exam, she appears generally well appearing in no acute distress. In her HEENT exam, she has her oral mucosa is pink and moist with good dentition, but she has 2 oral ulcers, one on the palate, one on the buccal mucosa. And those ulcers are well circumscribed with red atrophic center. And her face looks edematous compared to her old pictures. In her cardiovascular exam, she has regular raytime rhythm, no murmurs, rubs, or gallops. In her pulmonary exam, her breathing is unlabored and regular, but breath sounds are decreased in the lower lobes. Her abdomen is non-tender, non-distended, and there are no palpable masses. And her neuro exam is normal, within normal limits. In her extremities, she has 3+ pitting edema up to her knees bilaterally. And I can either stop here or give you the initial labs. Maybe I will get your thoughts here, and then I will continue on to the initial labs.
Yeah, that sounds great. Kansu, such an interesting aliquot. Maybe I'll start with the past medical history section, and I'll let Alex and Austin digest a very interesting physical exam. So, I guess as a young patient, there's no past medical history, but the herbal supplement kind of makes me think, because I know there's some association with like renal, kidney disease, interstitial nephritis, or related things, which may be associated with the dark urine, or that could be there could be an association here, although it doesn't seem to explain other systemic findings, including the arthritis and the mainly the arthritis. I'm always open to learn more about side effects associated with herbal supplements. And then the family history of hypertension, it doesn't add too much here because it seemed to be in a onset of a typical, I guess it seems that there's maybe a little bit earlier onset for the mom, or actually I think it's a pretty typical, and compared with this patient blood pressure, which is actually low. So that I don't, it doesn't add too much to my differential at this moment. And then a college student always makes me think of exposure to infections like meningitis, putting them at high risk. And I think systemic infections could be associated with like endocarditis, or like having joint consequence on the kidney and the joints as an inflammatory, causing inflammatory conditions. But the patient didn't seem to have other signatures of meningitis at this point, like no fevers, and I think neuro exam seems to be pretty reassuring. So I think those so far don't add too much. And then smoking history, yeah, I think I'll just keep that in the back of my mind. And yeah, Alec, I'm sure you have a lot to add on about the physical exam, or if you have other thoughts on the past medical history report.
No, excellent. Thanks so much, Mengyu. So I think the weight loss from the supplement is certainly an interesting piece of history, and really sort of the main signal that we have from the history. And anytime I have patients that take supplements, it's really important to see if you can just track it down. Get on your phone, find a picture. Is this what you're taking? Or have the family member bring it in, because really taking a close look at the ingredients is really critical to help build your differential and to see if this is signal or noise. So I think I would be investigating that a little bit further. Particularly when I think of supplements, I often think about how the liver may be affected, and how that could play potentially into the edema. But we can get more into that on the examination. The past medical history doesn't strike me too much, but I'm just sort of keeping that in the back of my mind. And then the college students, I just think about exposures, frequently infection, and then just adding on to the potential for meningitis, but mononucleosis or the related syndromes would be something that I would be considering as well with everything going on. And, I think something that I may have missed or we didn't get was a sexual history. And I think that would be very important, not only to risk stratify, from an immunosuppression standpoint, but use sort of other risk factors for sexually transmitted infections and, like hepatitis or other things as well. And, when we get to the exam, I think things that really strike me is we don't have a fever yet, but I think there are other signs that we're dealing with an inflammatory process here. The heart rate for an otherwise young person is certainly concerning. And then although their saturation on room air is normal, the presence of tachycardia in the setting of the significant sort of immobility and the background of inflammation definitely makes me concerned about a pulmonary embolism, and something we're going to have to consider as we're going forward. And as we talk about the edema, frequently the kidneys come to mind. And when like Robbie says, anytime you see edema, you want to look up. And we didn't get any clear stigmata of significant liver disease on exam. And I don't know if Tansu commented on the JVD, but it wasn't mentioned. So I'm going to just go out on a limb and say that it wasn't present, which certainly, if we're thinking about a systemic disease, really puts the kidney on the hook here. And I am struck by the blood pressure, because typically if people, with inflammation have a nephritic syndrome per se, typically you would be hypertensive and not normotensive like this. So either we're dealing with a non-nephritic process, and this is potentially nephrotic, or sort of some combination of both. Or, she has other reasons to be hypertensive, is volume depleted or something else. And, again, something that also strikes me is that most people that get very edematous, and this patient is profoundly anosarchic, I would call it, given the extent of the edema, is the weight loss. And those two in combination should definitely be putting up red flags in your mind, because most people that get edematous gain weight. So we're going to have to explain that, and well, likely multiple processes that are going on here. As far as pertinent positives on the exam, the ulcers are very interesting in that the differential, not only with inflammatory signature, with many of the autoimmune and autoinflammatory diseases being associated with ulcers, but also some of the infectious etiologies as well, that have a more subacute to chronic time course. And, it seems like the cardiac exam was benign, and with the time course, definitely thinking about endocarditis. The absence of murmurs is insensitive enough, but in the purposes of a diagnostic exercise, I'm going to try to say that it's a little bit less likely, but know that the exam is imperfect. And then the decreased breath sounds in the lower lobes. I'm not clear if that could just be pleural effusions, which is certainly evocative with the other signs of potentially anasarca, or whether this could be atelectasis or something else in the lower lobes. And no hepatosplenomegaly that was noted, no stigmata of cirrhosis. And then the edema, which is profound, and that is going to have to serve as an anchoring point, is something that we're going to have to explain in this otherwise previously healthy patient. And then something that we were missing that I'd love to get more history on is the joint exam based off the presentation, and whether there's synovitis, is it red, are there other joints involved, what exactly is the distribution? And I think that will be very helpful to clarify going forward. And then with the ulcers, just going back to the history as well, common things being common, herpes is a very common cause of ulcers, and getting more into the risk factors for that, or you can just have it because most people do. And I think those were my initial thoughts. So I think lots of things going on in my mind. I think I'm very struck by the edema, the background of the tachycardia, the oral ulcers, and the arthritis, which hopefully we'll get more information on. It is very evocative of inflammatory syndrome with a center in the kidney that we're going to have to explain. But I'd love to hear how Austin is synthesizing this as well.
No, amazing thoughts to you both, and I don't have much to add. I think to your point again, it's so busy that how do we gain confidence in what problem we need to solve? And I think the striking nature of the volume overload on exam with the weight loss by history, as we corroborated, is something that I think is going to be key in solving this case. And I think that narrows down differential diagnosis significantly. And then if we not only add causes of anasarca that could cause weight loss, that can also cause facial edema, I think that list is relatively short. I sort of like to lean in on my approach to facial edema just to see how much progress we can make and overlap the other features of her presentation to see if there's anything that hits. So I think, as Alec already outlined, and as Robbie likes to teach us, there's basically two types of swelling or inflammation anywhere. It's either an inflammation, an itis of some kind, or there's an obstruction of blood flow, right? So as far as the obstruction of blood flow, we can think about, as Alec mentioned, SVC syndrome. Is there enough for us to say, oh, SVC syndrome, why would this person get SVC syndrome? Suppose we could evoke a mass or lymphadenopathy that could contribute to that. But I'm not sure it explains the rest of the total body edema. So I think that would be lower on my differential right now. As far as more systemic illnesses, so nephrotic syndrome, as Alec mentioned, not certain, depending on the etiology, I suppose we could invoke how that could cause oral ulcers and the bony signature, but we didn't, or joint signature, but that's a bit hard to make progress on. There is a type of dermatomyositis that can cause facial edema with, and it certainly can have prominent joint manifestations. I don't classically associate that with sort of anasarca, but that would be a consideration. Thyroid disease could be a consideration. And then given the supplement history, I would be remiss if I didn't mention like dish or dress, as it was formerly called. It certainly can cause facial edema, certainly could cause a systemic signature throughout. But again, we'll have to sort of make progress as far as what the exact supplements you were taking were. And then lastly, she is of the right demographic to consider what's called like idiopathic capillary leak syndrome, or like Clarkson syndrome, since this is CPS. But I think it's far too early to try to make progress. And then, as I think other people have alluded to, maybe the ulcers are a sequela of whatever inflammatory syndrome this patient has, as opposed to signal of the disease itself. So I think the labs will be interesting. I think gaining clarity on certain aspects of the exam, and as Alec highlighted, will be helpful. But wow, really interesting case, Tansu. So excited to learn more.
Really, really great thoughts. Just to answer some of your questions. So this patient was actually not sexually active, and she did not have any genital ulcers. And in her her joint pain, as she reported, was only localized to the small joints of the hands and the wrists, and it wasn't generalized, like it was just in the hands. And yeah, so those are just some extra information about her physical exam. And there was no JVD, by the way. All right. Moving on to her labs. In her CBC, her white blood cell count was 6.3. She had the hemoglobin of 7.5 with an MCV of 76. Her platelet count was 67,000. In her metabolic panel, she had a sodium of 132, a potassium of 5.6, BUN was 26. Creatinine, her baseline was 0.49. And in this visit, her creatinine was 1.45, and over the course of the hospital stay, it increased to 1.75. Her calcium was 7.3. She had a total protein of 5.5, albumin of 2.1, CRP was 3.14, ESR was 76. She had a D-dimer of 3.21. Transferrin saturation was at 12%, and her ferritin was 107. And her folic acid was 9, vitamin B12 was 115. She had a triglyceride level of 3.72. Total cholesterol was 287. And in her urinalysis, there was 3+ protein, 130 red blood cells, and 48 white blood cells. And in her 24-hour urine protein, she had 3.6 grams of protein. And I will stop here. Mike, to you.
Thank you, Tansu. This is a very helpful aliquot. I think before analyzing the CPC, I think what we were looking for the whole time is the urine studies confirming whether it's a nephrotic syndrome or nephritic syndrome, or kind of a both. So I think I'm seeing like definitely meeting the criteria for nephrotic syndrome with the protein more than 3.5 and hypoalbumin, low albumin, and I think the cholesterols are elevated. But there's also 100 RBC, which makes it also nephritic. So I think we're looking at glomerulonephritis that fits the history of dark urine. And although what was unexpected from the vital sign is the blood pressure being low, since usually it's high if there's nephritic syndrome. My understanding is that the RBC, I think if it's from a microscope confirmed, yeah, it looks like it's confirmed like to be RBC. So I think again confirmed there's nephritic syndrome, and the differential will be somewhat different. The next step would involve like complements as the initial point, and then thinking about the ANCA-associated or polyimmune and or complement mediated that could be have include the differential that was mentioned earlier. But then also when I saw the CBC, I think when you see platelet and hemo being low and anemia, I always have to first in the first pass rule out anything MAHA related. So we'll do hemolysis labs to make sure that's not the case. So and otherwise it could also be if it's not MAHA and if we can rule out that with hemolysis labs and plus minus a blood smear, then we can think about autoimmune related, like even Evans syndrome, or could just be part of the systemic autoimmune disease causing these changes. Or an infection, which we learned like infection, a lot of systemic infection actually cause thrombocytosis, but with the platelet being low, I think there are some limited differentials for that. Although I'm not thinking about anything tick related at this point. I think like a systemic autoimmune disease seems more plausible at this point. But yeah, I'll pass them back to Alec and Austin at this time.
Go for it, Austin.
Sorry, yeah, no, not really too much to add here. I think as Mengyu mentioned, I think from an initial triage standpoint, we're going to have to look at the anemia and thrombocytopenia and make sure that we take a breath and evaluate for the most concerning potential etiologies of that, as Robbie likes to say. Again, I'm sort of struck by your analysis as Mengyu latched on. Yeah, so as Mengyu had latched on to, and there's a pretty small combination. There's a pretty small differential diagnosis for the combination of nephritic and nephrotic syndrome. But again, there are some features of the case that maybe will make us wonder, what could be happening. Again, there could be the possibility of concurrent like volume depletion, for example, that could explain the low blood pressure. But I think that's where my mind is having a little bit of a disconnect. As far as the other labs here, sorry, I'm on my phone, and so it's a little bit hard for me to see, but it seems like the D dimer is probably elevated. The patient is iron deficient. There is low folic acid, low B12. And so there seems to be a signal for just basically malnutrition or malabsorption, which Tadzu sort of maybe gave us hints at based off the patient's diet. And so now I'm wondering, in combination with the renal findings, like, is there really signature in the GI tract that we need to be focusing on? But yeah, no, lots of information. And Alec, what are your thoughts here?
No, awesome thoughts, Austin and Mengyu. I don't know if I have too much to add. I think trying to think of the overlap between sort of nephritic and nephrotic syndromes is difficult. I agree that TMA will be critical to rule out first. I think something that strikes me is, what are causes of nephrotic syndrome, which is certainly evocative because the patient has anemia, right? Sorry, the patient has greater than 3.5 grams of proteinuria in 24 hours. They have edema, right? And the albumin is low. So they meet the criteria. So what are the causes of nephrotic syndrome that cause thrombocytopenia? And I think it's sort of the viral syndromes like HIV in particular, and then the hepatitis are one things to think about also. And then lupus would be another one to be sure we're not missing, and the patient's are right age demographic for that as well. But it's also possible that the patient just has multiple things going on, and it's hard to know which is contributing to which. And the B12, if it's same as my laboratory, that's quite a low B12 level, as Austin had mentioned. And with the anemia and thrombocytopenia, and I agree we need to send the hemolysis studies, but could we be dealing with a pseudo TMA here as well from B12 deficiency? And what would be driving that, either just because of a poor dietary intake, or is there an underlying pathology, either celiac disease or otherwise, that's preventing proper absorption of some of these vitamins? So, I think the differential remains broad, and I agree with you both that it's sort of, there's lots of Venn diagrams here that are sort of overlapping, but not perfectly enough, at least in my mind yet, to allow me to make too much more, specific diagnoses. But I think sort of pursuing the diagnostic workup frequently with serologies. I'm still interested to know, what's going on in the lungs, just confirming that that is edema and that the patient doesn't have DAH or something like that, because that could potentially change the differential. And then with the dimer being that elevated, and the patient has nephrotic syndrome, so I feel like the hypercoagulable risk is just even higher. I do still think we need to rule out that the patient isn't having pulmonary embolism. And beyond that, yeah, I think I share the same concerns, and looking forward to hearing more as far as other serologies that we got next, any potential imaging, and then thinking long term if those aren't revealing, whether or not we would need to pursue a renal biopsy. But I think time will tell. But I'd love to hear more, Tansu.
All right, thank you so much again. Great thoughts. And I just want to clarify a couple of things about her weight, especially. So she reported that weight loss a couple months before her current presentation. And since this is a really old case, I don't have at hand what her current weight was at her hospital stay at this time. So sorry about that. And about her hemolysis labs, like I don't have everything, but I will share with you the labs that I have. And her her Adams TS13 level was obtained and it was greater than 80%. And her direct Coombs was positive, indirect Coombs was negative. Also, her complement levels were obtained. Her C3 was 43, the normal being between 80 and 178. And her C4 level was 4, the normal range being between 12 and 42. And her anti-MPO and anti-PR3 antibodies were obtained, which were negative. And her ANA was positive, and the titer was 1 to 3,200. Her anti-ribosomal P protein and anti-nucleosome and anti-histone antibodies were all positive, and her anti-double-stranded DNA was also positive. Her HIV and hepatitis panel were negative. And because the patient had cough and some mild sputum production, and she also ran a fever during her hospital stay, her blood and urine cultures were obtained, and they did not show any growth. And she also got an echo, and her echo showed no abnormalities. And she also got a chest CT, which showed linear atelectasis in the inferior lobe of the left lung and interlobular septal thickening in the bilateral basal segments. And she also got an ultrasound of the kidneys, and it showed the kidney dimensions increased bilaterally by 12.5 centimeters, and also increased echogenicity of the parenchyma was observed. And I will just stop here to hear your thoughts, and then I will reveal the final diagnosis in the next aliquot.
Yeah, thank you, Tansu. That's very helpful. I think when I see the positive anti-dsDNA along with the high ANA titer, I think especially the dsDNA kind of confirmed the lupus diagnosis with definitely meeting the criteria with the antibodies and the clinical syndrome involving several organs. Especially the kidney brings up the most points. And with regarding to the, so I think then the ANA, the full panel, ANA panel, like I learned that the more antibodies positive you had, the more it's suggestive of lupus. And the histone, anti-histone positivity could be just part of the lupus. And although I thought about the drug-induced lupus, but this condition rarely has positive dsDNA. So I think that's just part of the lupus to me. And the ribosomal P protein could also be part of the lupus. And I think it's also kind of increase the risk of like lupus encephalopathy. And I'm trying to think what other conditions are kind of associated with this antibody, but this patient, I think we don't see any encephalopathy here. So yeah, and I'm also glad. So and then the complement, as we mentioned earlier, kind of confirmed this like a complement, low complement, hypocomplementemia confirms a complement mediated a process. So I would suspect this patient has type 4 or class 4 lupus nephritis that would justify a kidney biopsy along with very aggressive treatment that includes positive steroids and immunosuppressants. I think I'll pass on the mic to Alec and Austin for the further reflection and maybe analysis of the imaging. And maybe before that, I kind of thought about the D-dimer being positive in the setting of, a nephrotic syndrome present, which, and we know nephrotic syndrome is associated with risk of thrombosis. So but also, although the D-dimer could also be part of the as a non-specific inflammatory marker, but I agree, if the chat CT is contrast, then it could help us rule out a PE, or maybe just if there's any leg swelling to rule out DVT as part of the picture. Yeah, I'll pause here.
Yeah, no, excellent thoughts, Mengyu. I think I totally agree. Drug-induced lupus is typically, it doesn't cause significant end organ damage, and so although the histone antibody is positive, it's not specific. So I agree with the presentation. It seems more likely to be sort of primary lupus, and if you think about all the SLIC criteria, the patient meets them all with the cytopenias and the positive DAP without clear evidence of hemolysis. And the hypocomplementemia and the ANA positivity and the active urine sediment and whatnot. So I feel comfortable with that diagnosis. But for prognostication, as you said, the degree of proteinuria certainly suggests possibly class 5 because that's what causes membranous nephropathy. But the hematuria is discordant with that. And the rate of rise in the creatinine certainly makes me concerned for class 4, which is probably the most aggressive and concerning, as Mengyu had educated us on. So I'm just trying to think if that explains everything in this case. And I feel like it could, some of the vitamin deficiencies, lupus can cause enteropathy and other things, or that could be true and unrelated, just related to the diet and other things. So just keeping that in the back of my mind. And I still am worried about, the possibility of thrombus here. And the chest CT, it seems like it was potentially with contrast. The interlobular septal thickening is sort of nonspecific, could be edema, could be something else. There's nothing clearly in the alveoli, so I guess I'm less concerned about DVH or something like that. But I guess happy to learn more there. And as far as how we're going to confirm this diagnosis, I think just for treatment purposes, I agree with Mengyu that the biopsy is probably the next step here. And hopefully, I think we would get the biopsy, confirm the diagnosis, initiate treatment, and see the majority of these get better, and decide if we need to do any other investigative workup for some of the vitamin deficiencies, or whether we're just going to blame that all on the diet. But I feel like those are just really just adding on to really just reiterating what Mengyu said. So Austin, do you have any other insight before maybe Tanzu gives us more information?
No, not really. I think, as you said, we've diagnosed lupus, and this patient has the right sort of background for lupus. But I think you're asking a key point of, does it explain every finding that we see here? And I think lupus is a great mimicker. And so basically, based off my knowledge of lupus, I think it seems realistic that it could cause all these things. I think, if we go back and we say, instead of, okay, it could be something else other than lupus, we could say, what in addition could it be, or what complications from lupus or manifestations of lupus could we invoke to make sure we explain all of the clinical picture? I'm not entirely sure if it's relevant in this case, but since we have the sort of mixed nephrotic picture, and as we mentioned, the sort of differential diagnosis of that with low complements of basically MPGN and lupus, and so this patient ends up having lupus. Otherwise, if their complements are normal, it's like IgA. So I think of the again, if we go back to the edema, lupus is associated with like a vascular leak phenomenon, and could, I suppose it can cause like a TMA as well. So, biopsy would be helpful in that regard. But again, we have signal that it's presenting as an MPGN or as a, yeah, like basically a mixed nephrotic picture. So I don't want to sort of go in too much into this, just because I'm probably going down the wrong path, but excited to learn from Tansu about the resolution of the case.
Awesome, great thoughts. And you were spot on. So I have the biopsy of the kidneys next, and it was seen that she had glomerular, mesangial, and endocapillary proliferation, few polymorphonuclear leukocytes, hyaline thrombi, wire loop lesions, fibrocellular crescents in 2 glomeruli, thickened basal membranes, focal atrophic tubules, and fibrointimal sclerosis. And no amyloid-like material deposition was seen. And in the direct immunofluorescence exam, there was immune complexes with IgA, IgM, IgG, C1q, and C3, and kappa and lambda deposits, which is the full house pattern. And her lupus nephritis score activity index was 12 out of 12, and her chronicity index was 2 out of 12. And the diagnosis of diffuse proliferative and membranous lupus nephritis, class 4-5, was made. And the patient was started on appropriate therapy with pulse corticosteroids and mycophenolate mofetil. Would you like to share your reflections?
Yeah, thank you, Tansu. This is a very lovely case. I think somewhat a classic presentation for lupus. Yeah, so really helped me kind of with some interesting background information that we were initially wondering if it's associated with the picture. And the vitals are still is something also we kind of reflected on whether it's typical for this or not. But I think from the get-go, there's a sign of the multi-system involvement. So I think we were kind of on the right path to, and especially urine is like a strong clue for the gives a very clear path for the diagnosis. I think that was very helpful. And I realized earlier I kind of missed, I kind of somehow I felt like you said the antihistamine were positive, but I think looking back on the whiteboard it's negative. So I think that also just wanted to clarify. Earlier I thought it was a positive. So it's talking something non-related, but yeah, I want to see if Alec and Austin has reflection.
No, just an awesome case, Tansu. Thank you so much for taking the time to present it. And no wonder you wanted to do medicine if that was your first patient. Just imagine just the learning and the journey that you were on to make that diagnosis. And if I'd love to know how the patient did afterwards, and how some of these labs improved, and hopefully they did well, and they got back to being just a young student, living their life. But yeah, I think it's lupus, I think it's really disorienting when you get all the symptoms, and then you get the urine and you're just like, okay, and then you know what to do next, sort of. And yeah, just an amazing presentation, and taking the time to present it, and going back all the way to your first patient, and to be able to present like this, it's just awesome. So I'll pass it to Austin, see if he has any other reflections.
No, thanks for sharing. Sorry, I'm not able to share my video. I'm sort of like stuck in a corner somewhere in the office, but thanks so much for presenting the case, Tansu, and such a rich discussion. And lupus is a tough diagnosis for diagnosticians as it is for patients. And I think as many exposures to as many lupus cases as possible is wonderful, since it can present in so many different ways. And so, yeah, I'd love to hear Tansu's reflections to see what they thought might have been other manifestations of her disease, like if there's GI involvement or anything like that. So thank you so much.
Thank you for your great discussion. Unfortunately, I don't have any information on the GI involvement, and I reached out to my friends who have access to the system to check on like how the patient is doing, what her follow-ups were like. It seems like she's doing okay, and she still has mild proteinuria, and she was on immune suppression for maintenance, but she's doing fine, and she went back to, it seems like she went back to her like usual activities. And why I wanted to share this case with you was because at the time when I saw this case, I had no idea that lupus nephritis could be the early first, like one of the first presenting symptoms in lupus. And what I learned back then was that lupus nephritis can indeed present early in the disease course, especially in males, young patients, and non-white patients. So these demographics were at increased risk of developing lupus nephritis early on. And also clinically evident kidney disease was seen in 1/2 of the patients, and 10% of the lupus patients develop end-stage renal disease eventually. And levels of the double-stranded DNA antibody levels correlate with the disease activity, which was very high in this patient. Also, what was very interesting for me was the immune fluorescent exam in this patient. And I found out that the histopathology can be varied in lupus nephritis, and it can be confused with other immune complex mediated glomerulonephritides. But some histopathologic features are characteristic for lupus nephritis, and the full house immunofluorescence pattern as seen in this patient with the IgG dominantly and IgA, IgM, C3, and C1q is actually very typical in lupus nephritis, but it's not specific because it can also be seen in endocarditis, HIV, hepatitis C, and PSGN as well. So also one more thing that I want to share, the intense staining for the C1q complement has been shown to have a similar sensitivity and specificity for lupus nephritis as the full house staining pattern. So this was also very interesting. And the biopsy is indicated when the urine protein excretion is more than 500 milligrams per day, and if the patients have an active urine sediment and persistent hematuria, and if the patients have rising serum creatinine, just like in our patient. And the timing of the initial biopsy is really, really important, and ideally performed promptly because of the subsequent initiation of the treatment, and it improves outcomes regardless of the histopathologic class.
Thank you, Tansu, for your teaching.
You're so welcome. I hope you enjoyed the case. I'm sorry that I didn't have all the details because this is a case from 2019. But yeah, I hope you enjoyed.
Don't apologize, Tansu. It was amazing. You did an awesome job. We don't need all that information. You gave amazing teaching and presented just a wonderful case to learn from and reflect upon. So I know Ambush is dealing with a toddler that is interrupting some of her teaching. So I want to kind of wonder, just from time perspective, Tansu just gave some awesome teaching. So maybe we can just end it there, and just thank you again for a wonderful case. And I hope everybody has a great rest of the day.
Thank you, Tansu, Parisa, and Ambush, and everyone. Bye.